Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. It's my pleasure and privilege to welcome you to this webinar where we'll be exploring the response to the hepatitis C epidemic among the Rohingya refugee population in Cox's Bazar, Bangladesh. As you will be learning, this population has the largest, highest prevalence of hepatitis C in the world. And it's important for us to explore the reasons for that and the response in testing and linkages to care and treatment. And you'll be hearing from a variety of important partners how they are responding to this epidemic. Next slide, please. I encourage you all, this is a very interactive discussion that we encourage. Please submit your questions to the Q&A feature of Zoom. Speakers will either respond to those if they're questions of clarification, and we'll do our best to reserve those and bring those into the discussion later in the webinar. This webinar is recorded and posted on our website. You go to globalhep.org to access that recording as well as the slide presentations that you'll be viewing. And you can sign up to our newsletter while you're at globalhep.org so you can be made aware of other activities that the coalition has underway that you can be a part of, as well as future webinars. Next slide. We've been doing this webinar series since 2020. We are closing in on about 70 webinars now on a variety of different topics. So you can look at that rich library when you go to globalhep.org. And we are very appreciative that we can add this webinar focused on this key population to this series. We have long been aware of this hepatitis C epidemic among the Rohingya populations in Cox's Bazar, Bangladesh. I want to thank Dr. Muhammad Ali for making me aware of this almost 7 years ago, which preceded his publication of a survey that he and his colleagues conducted among the Rohingya population, revealing very high prevalence of hepatitis C, both among men and women. And you'll be hearing about additional surveys now that have validated that survey that Dr. Ali and his colleagues conducted. And I really appreciate Mohammed joining me in moderating the discussion later in our program. Next slide. So today you'll be hearing from Dr. Tanjida Basanti, who is a Humphrey Fellow here at the Coalition, who is a clinician in Cox's Bazar caring for persons in the Rohingya community. You'll be hearing from Dr. Wasim Farouz from MSF, who's also been involved in the response. Dr. Tran Min, who is a WHO representative in that region. Then following that, the representatives from the International Organization for Migration, IOM, who'll be again describing their response to this epidemic. And then we'll have Dr. Abu Buya from the government of Bangladesh also talking about the national response. And then we'll have a panel discussion, then with a closing by Dr. Basanti. So again, I encourage you to submit your questions to the Q&A and use your chat function as well. And really look forward to this program. Next slide, please. So let me turn it over now to Dr. Tanjida Basanti, who'll be giving her remarks. Tanjida.
Thank you, Dr. John. Please let me know that I am clearly audible and not.
Yes, loud and clear.
Thank you. So, good morning from Coalition for Global Hepatitis Elimination Program and obviously Humphrey Fellowship Program under Emory University. It is truly a pleasure to see all of wonderful and influential health partners together here, especially familiar face from the Rohingya response in Cox's Bazar, Bangladesh for me. And I would like to start now. This first slide is showing that actually Coalition for Global Hepatitis C Eliminations is a non-profit wings founded 2019 under the Task Force for Global Health. Often it's called CGHE. And in a broader picture, ensure capacity building, global partnerships, knowledge sharing, for targeting elimination of hepatitis, strengthening research, evidence-based generations, and along with the tool for evidence generation, those countries who actually affected from viral hepatitis. And finally, obviously, has some influential capacity for policymakers, public speakers, developing awareness and urgency, understanding the urgency and ground for hepatitis C elimination program. And for that, I would like to mention about task force. That task force for global health works in a global partnering project, more than 150 countries, obviously including Bangladesh. Previously, they collaborated with BRAG and ICTDRB. And next slide, please. So now we are deep down to our main focus in this webinar, hepatitis C response in Rohingya populations. Before that, you can see that there is a picture where there is a geographical picture that shore of Bay of Bengal, a tiny country that is Bangladesh, and the east part nearest adjacent neighboring country that is Myanmar, and the marking red areas that is Rakhine or Arakan state of Myanmar. In August 2017, following widespread violence in Myanmar's Rakhine state, an estimated 700,000 Rohingya fled across that time and entered into Bangladesh in the month. For this reason, that the biggest refugee response occurred. And the second picture is showing how Rohingya response is operated from the very beginning. It's the multi-sectoral joint response planning, where there is a coordination of refugee relief repatriation, representation of Bangladesh government, and obviously UN bedded that is intra-agency working group, which is till 2025. And it is showing that health intervention is not only just a health focus, it is actually an integrated plan which coordinated by protection, nutrition, wash, and other site management, all the basic need for this refugee context. And I would like to request for next slide, please. In this slide, we can see a woman from one of obviously the camp along with her 3 kids, broadening and a smile into her face. Behind this smile, there was a life event. For some time, she begins unwell, often tired, weak, and without energy. And she noticed that something changing her skin colorations. That the thing, all of the matters she couldn't address properly at a time because of where the survival is a priority. She first choose for local healer, traditional healer first, where they couldn't figure it out about the curable, but there is lots of dilemma coming through. However, one day during the health screening procedure from a camp facilities, she offered a simple testing, and finally she got a name that is hepatitis C, which is fully not understandable by her, but she can assume that there is a illness, fear of stigma, fear of that how can she bear this kind of things. Along with, she has been told that her husband need to be tested. And along all of these things, she got courage to came with her husband, and through the all testings and enrolling the treatment plan. She completed her treatment, and this is the pictures actually after the treatment. And treatment for hepatitis C is not a lifelong, it is time bound. And after this picture, we can go for the next slide, please. And for the understanding of the situation in Rohingya camp, we have encountered numerous Amina and their husband and or individual, even though the pregnant mother, where hepatitis C in refugee context is highest burden globally. And the mode of transmission, there is actually lots of things coming through, like reusable needle and unsafe practicing piercing, unsafe sexual practice, even the mother to child transmissions. While the prevalence in general population, Bangladesh remains below 1%, but in camp population is worsening, that 1 in 5 adults. For the situation, there need to be upload for our influential all health partners like WHO, MSF, UN, other INGO and NGO obviously who are involved in here. So here it is only roadmap to we can pause here, or we can think some kind of roadmap that create a diverse like crisis shaped displacement, vulnerability, system inequity. This is the time for thinking for us. Next slide, please. In our next slide, that previously we are just talking about diseases in proportion, and here it is showing our inequality disease burden comparison of Bangladeshi nation to the Rohingya populations. Next slide, please. I would like to just give a glimpse at that we those who know Jon Snow, not in a Game of Thrones, but also that's a public health part. I believe Dr. John will clarify it more. So it's just think about pump handle driven hepatitis C transmission for Rohingya response. It will come more detail from Dr. John. Thank you. Next slide, please. In this slide, just framing of stakeholder, our understanding, all we are in here, where we are belong, what could be our responsibility, sharing responsibility, same interests, alignment we can and cope with. So government leaderships, where it is given us some source of policy alignment, global leading agency like WHO, here Coalition for Global Hepatitis C, other UN organization and INGO, NGO, even though the National Institute of Liver Foundations, all have some sorts of role, we have to be acknowledged. And next slide, please. This is the objective why we are today in here, some sorts of same interests, values, and alignment, more specifically raising awareness, mobilize actions, understanding the ground of hepatitis C burden, where it is epidemic or endemic, how we can introduce ethically. Refugees in a refugee settings, high percentage, and how we can more shared joint response, persistence gap, emphasizing urgency. These all are, along with strengthening collaboration. Here mentioned solutions, and we understand that solution is not just a blink of eye, but we can hope for solution for elimination of hepatitis C. And next slide, please. Next slide. So in here, we would like to draw everyone's attention regards of two questions. There are pulled in chat box. Whichever you feel most favorable, effective, we would like to hear from you. It will not take more than 2 minutes. And now I'm pausing myself, handing over rest of the session to Dr. John, but assuring it is just a glimpse. More yet to come from our most influential leading health partner in Rohingya response. Thank you.
Thank you very much. And as you learn, more about the response, and I'm sure will shape, how you respond to these, questions. But please submit your responses to these as you feel comfortable in doing so. But let's turn to our next speaker, Dr. Wasim Feroz, who's Deputy Medical Coordinator of MSF in Bangladesh, who will give us a highlights of the MSF response to this HCV epidemic. Wasim, over to you.
Good afternoon and good morning, everyone. Am I audible?
Yes.
Okay, this is Dr. Wasim Feroz. I'm the Deputy Medical Coordinator from MSF Bangladesh. So in this next few minutes, we'll try to explain what MSF has been doing in this Rohingya camp regarding this hepatitis C for the last few years. So currently, MSF we are working in this Rohingya camp for a very long time, and especially after this recent influx of 2017. Currently, MSF, we have total 3 field hospitals, 2 primary healthcare center, and 4 health posts in the Rohingya camp. So back in 2019, in one of our health facility, we have an NCD cohort, roughly 2,500. So while treating this one chronic disease, mainly the diabetes and hypertension, and we're seeing this cohort are very well maintained, despite they are repeatedly some of these cohort patients repeatedly admitting in our hospital. And when we have analyzed in one of our hospital database, we have seen roughly 10% of total admission, and almost 20% of our ICU admission are due to decompensated liver disease. And when we have analyzed our mortality data, it receives that amount 20 to 22% total hospital death are due to hepatitis C, some hepatitis B related complication. So at that time, a thought comes to our mind, like this cohorted patient where we are taking their chronic taking care, why don't put another component, so another chronic disease which is communicable. So based on that thought, we start some kind of a random survey in our IPD and OPD patient, which give us a 19% seropositivity. It was, we tested for a couple of days, and it is 105 Hep C RDT positive out of 546. And by this time, we kind of identified this as a hidden communicable threat to our NCD and IPD patient, as well as for the total community. After that, in October 2020, MSF, we have come forward for providing hepatitis C treatment, initially with this NCD patient and the critical patient who has been admitted to the IPD. So at that time, we are considering that as Dr. Basanti clearly said, in Bangladesh, the hepatitis C prevalence is less than 1% among the Bangladeshi nationals. And we do not have that much experience, at least the Bangladeshi doctors, in treating hepatitis C. So at that point, we bring out this MSF real world learning. And before that, in the last recent 10 to 15 years, we have been operating hepatitis C program almost in 15 camp, and one of the biggest is in Cambodia, which we ran hepatitis C between 2016 and 2021, and another is Pakistan, where we have run hepatitis C campaign 2015 to 2024, and we have treated roughly 29,000 patients in both projects. What we have learned from our Cambodia project, so in this project previously, in the beginning, we learned very extensive program. We used to do the genotype, we used to do the fibroscan, we do the UpRi score and everything. As MSF work most of the time in low resource setting, gradually we are trying to get, okay, how it can be more affordable for the population, also operationally sustainable. And between 2016 and 2019, we exercised different model in Cambodia. And every time we have seen there is sustainable virological rate between 97 to 98%. This gives us a confidence that it can be managed in low resource setting. And we come to this learning from our Cambodia project that visit can be reduced to between 5 to 8. We can avoid the genotyping by, as we are now using the pan-genotypic drug, we can reduce the test only for the selective patients. And for the defining between 12-week regimen and 24-week regimen, we can rely on our clinical suspicion. And as we do not have a lot of opportunity to directly communicate with the hepatologist, so this model helps us to continue activity in low resource setting. The basic difference between the WHO model and MSF model is we don't do a lot of tests. What we do, we basically do the RDT of the suspected case. Then if RDT positive, we go for the confirmation by PCR, and we use our GeneXpert platform here. And then if PCR positive, we do a clinical assessment. So mainly we check if patient is decompensated or not. So ascites, jaundice and hepatomesis or hepatic encephalopathy. And if there is no symptoms, we go for 12 weeks regimen. And so the main difference between WHO and us, we avoid some additional tested, and we mainly based on clinical judgment, how to decide between 12 weeks regimen and 24 weeks regimen. So then between 2020 to 2024, in the camp, MSF is the only organization who are dealing with the hepatitis C. And between this time, we have 2 facilities, and our capacity was a bit minimum. So in one facility, we able to enroll 150 patients per month. And in another facility, we able to enroll 15 patients per month. During these times, as the demand was enormous, we have to come up with some kind of criteria. So mainly how we have prioritized, we prioritize our patient from the NCD cohort, then patient with signs symptoms of decompensated cirrhosis, any partners of the patients in our mental health cohort, and patient with co-infected with HIV and hepatitis B. And especially if any patient requires any surgical intervention, we have also tried to prioritize them. After that, if we have room, then we are prioritizing the patient who are more than 40 years old, who have been presented in our hospital. And this is our criteria, as I have already explained. We used to do the hepatitis C RDT. Then if positive, we check the viral load. If viral load positive, we check the clinical signs of clinical decompensation. If there is no, then we go for 12 weeks treatment. And if yes, there is clinical sign of decompensation, we go for 24 weeks treatment. The advantage that it increases access to care, and it gives us further decision making and reduce the staff workload. So we placed a very few medical visit for the patient, and it is remained between 6. If there is 12 weeks regimen, we have patient has to come 6 times in the facility, and if it is 24-week regimen, they have to come additional 3 times in our facility. Between 2020 to 2024, we have screened total 30,000 population and enrolled more than 10,000 patients. And we have seen almost 99% of the patients, they have completed their treatment. And in terms of our cure rate, we have 94% cure rate, both in the 12-week regimen and 24-week regimen. Then, as we have already completed our NCD patient and our IPD complicated patient, we are checking like how to open our cohort for the population. At that time, back in 2020, there was not a lot of study or evidence generated in Bangladesh, but gradually we have seen some study has been published. But we would like to check the prevalence of active hepatitis infection. So by this, we ran a seroprevalence study back in 2023 mid, and what we have found that also supported some of the previous studies. So we have seen that the seroprevalence is 29.7% and the active HCV infection is 90.6%, which means nearly 1/3 of the adult population that has been exposed to hepatitis C in their life, and 1 in every 5 adult population, they need active hepatitis C and they need treatment. Besides, also what we have seen, there is higher seroprevalence among the females, according to all ages, and lower seroprevalence among the young adults. And when we have estimated, based on that time available UNICEF population data, we have estimated there are 85,000 adult population who have active hepatitis C and who need treatment. So that back in 2024, also WHO has been come up with their hepatitis C surveillance. And then based on our evidence, we have planned for scaling up treatment. So MSF planned for additional 30,000 treatment for completing within 1 year. And we planned additional hepatitis C treatment center. And we proposed extensive health promotion, community level screening, and our approach was camp by camp approach. And the target we take, the dedicated MSF camp, we will bring 90% of the affected patient under treatment. So this is our diagnostic approach. Initially, MSF, we planned for 9 camps. So on these 9 camps, we will do the mass screening and we'll bring them all positive patient under treatment. Later, we have take additional 2 camps, so total 9 camps. And our screening criteria was all adult population and the index case. Like if any child of that particular parents who are positive, we are bringing them under the screening approach. And we are doing community level screening, camp by camp approach. Initially, we have 3 teams. They started 3 camps at a time. And we are doing same day sample collection for the PCR. And then we are running it our Gene Expert platform. And within 24 to 48 hours, we are initiating the hepatitis C treatment for them. So that is a bit unique, our community-based screening approach. So we have followed 2 models. One is door-to-door approach and one is sentinel-side-based approach. In the door-to-door model, our hepatitis C team member, mainly the nurse and Rohingya community-based team member, they are going to every door and they are screening the family member, going to the family. And in the sentinel-side-based approach, we are doing a bit more micro things. So in the camp, the distributed is around, each camp is consist of some block and each sub block is consist of some sub block. So we have been engaging with the community. We are meeting with the community leader, Machi and Imam, and we are asking, you don't need to come to the facility. MSF will come to closer to you, but you have to give us space. So they give us some, one day they give us a mock top, one day they give us mocks for 2 to 3 days. They have been seeing some picture on the right side. And we are doing the screening on that particular subject to reduce the community mobilization to the facility. And at the same time, when there is RDT negative, we are doing health promotion, how they can keep negative and how to prevent this. And if positive, we are immediately taking the sample and we are asking them to visit our clinic within next 24 to 48 hours. So this is the achievement of our hepatitis C test and treat campaign between April 2025 to March till now. Out of 11 camps that MSF assigned, we have completed screening in our 9 camps and 2 camps is ongoing. We are planning to complete those screening by next 1 and 1.5 months. In terms of RDT coverage, in the presented adult population in this particular camp, we have reached closer to 90% RDT coverage. And so far, we have screened roughly 150,000 population, and we have seen there is a 90% seroprevalence. our PCR coverage is 100% and PCR positivity is 28%. So the viremia is around 13%. And we initiated 16, almost closer to 17,000 population. There are few pending, mainly they are pregnant and breastfeeding, lactating women. Among the completed patient, we have did 8,000 SBR12, and so far our cure rate is 94.6%. So what we have seen, there are task force has been developed. There are other health workers, partners who have been doing also the things. And we can say that our simplified model can be adapted to scale up the things. And we will propose to hepatitis C integration in the general healthcare package. One of the things, though MSF completed the screening in their particular camp, there are other camps which need to scaling up the capacity to complete gradual screening. And another things we have been worried, the prevention and reinfection. We have already started to see some reinfected case. And as there is still quite some traditional healer, as Dr. Basanti said, there are some traditional healer, there is unauthorized practice, unsafe practice of needle ongoing. We need to prevent this. And there is still a question, we have some pregnant and lactating women, though that is widely not recommended to treat the pregnant and lactating women. We have a bit afraid if they might be lost in the follow-up. And at the same time, still, though there is 94% cure rate, there is 6% failure rate. So, so far, not within MSF or WHO, we don't have an answer for this population. And for the facilitating global access, we will propose to look for alternate, cheap, but effective, low resource conformative tool for the low resource setting. Thank you.
Thank you very much. Again, I encourage you to submit questions in the Q&A, and then we will be exploring this presentation in more detail during the discussion. And thank you again, Wasim, for an excellent presentation, really an excellent response to this epidemic in many ways. And we'll be exploring that progress and the work yet to be done in our discussion session. Let me turn it over now to Dr. Tran Minh, who's the lead of the WHO emergency response at Cox's Bazar. Welcome.
Thank you, Dr. Ward, and good day to all our participants of this webinar. Thank you for organizers to inviting WHO also to share our experience on this hepatitis C control effort in Cox's Bazar. May I have right to share my screen?
Yes, please go ahead.
Is my screen up?
Looks great.
All right, it's in the full screen.
Yes, exactly.
All right, so let's go. So indeed, so thank you for the previous speakers also to give some of the introduction to the subject, and indeed we need to acknowledge MSF who have been pioneering in this effort to control hepatitis C in the Rohingya population. So yes, my name is Tran Minh. I just joined WHO sub office here just a month ago, but I think this is such a nice story that I would like to share with you, so that we are on. Yes, so on the page. So I would not spend too much of background, but just to emphasize that we have a huge population here. Nearly 1.2 million, and in this condition, the health system, with multiple partners, a lot of humanitarian actors on the ground have provided from health posts to primary health centers, field hospital, field laboratories. I just would like to quote a little bit that Tanjida already mentioned about this administrative structure. So it's quite not complex, but it's actually multi-layered. Right? To see that we have in the top of Director General of Health Services of a Minister of Health. So this triple RC, we call that what we call the Refugee Relief Repatriation Commissioner. But on site, we have on the health side, the district civil surgeon. So it's quite complex, different layer of administration, but the health sector is coordinated by WHO. So yes, it's actually one of the most densely populated refugee setting globally. And in this kind of condition, as you have been described already previously, we have persistent transmission of epidemic diseases with high burden, particularly TB, HIV in some extent, but extremely the hepatitis issue, not only C, but also B. But this is why in this kind of setting, we ask ourselves what would be feasible, how to control some of these high burden communicable diseases. We're thinking that why, for instance, TB has remained to difficult control, but hepatitis C, with the experience of MSF, has shown some potential on better control or even the elimination. These are where our starting point. I quote here very quickly only, it's already there's a few studies on the burden. And in the beginning, MSF study was called, but now we have also some other studies that showing MSF say that some 85,000, we could say that 95,000 of active cases estimated. So this is a substantial public health burden, and as we know, that is not only on end stage of hepatitis C, meaning the liver malfunction, even cirrhosis or hepatocellular carcinoma, but the example of patients show that fatigue and functional, general condition will drop quite dramatically with hepatitis C. So you can say that the burden of disease is substantial. So far, we have what we have faced is the challenge that has been the whole service delivery has been like very much disrupted due to, of course, not all partners on the ground. I see that the 49 partners on the ground delivering. So not all were able to let's say provide such seamless from detecting of cases to giving confirmatory tests and linked to care, and particularly the care session is what is very much the critical question, not only that detecting those cases, but how to provide the regime of this 3 months or 6 months of care. So this is our challenge, but how we see that we could do is, with partners that we can accelerate. We say that high level of control, but vision is that global elimination of hepatitis C by 2030, that WHO launched that initiative. And this was based on a number of factors. Actually, we are thinking that some of the key elements here is first of integrated care and how to rapidly to link it from screening to treatment, as well as we need to have a system in place to monitor, meaning the surveillance from the symptomatic to the surveillance of after that, how to referral for different point of services that I will say later on. So some of these thinking need to be behind how the response model would be shaping up. Here we have the map, as you see, of first on the left panel, you can see that how many of surveillance sites from the 17 hub to 24 sentinel center. And from the right panel, you can see how many of treatment centers that now 9 is what run under WHO coordination, but MSF just mentioned that they have 3 more treatment sites as well. So from screening to diagnosis, all these treatment pathways in coordinated manner with, of course, the government authorities as well as the partners. Here, like a treatment cascade, I just say that from when the patient walk into a health post or primary health center, up to screening, up to go to sentinel site to have sample collected, and after that confirmation if it's now confirmatory test is positive. So how we can refer to treatment centers and afterwards a follow-up. So as you see that this is what we see that is like a seamless flow from screening to treatment. Now, so the burden is enormous, but how we can think to scale up this. So first we have this established what we call Hepatitis C Technical Task Force, and we have been developing the guideline. This now has been finalized. We're going to launch in a week or so the new guidelines for Hepatitis C. And we have also to monitor that we have the real-time monitoring dashboard, as well as we are starting to think that how that MSF already has initiated some like community-based, I mean, or door-to-door way to reach those, not only that the patient seek help in our facilities. So we have trained more than 400 now of the healthcare workers to that, and with support of the partners, donors, we have been able to procure quite a number of rapid diagnosis tests, PCR reagents, as well as drugs. Now, what the current situation looks like. We have been screening more than 100,000 individuals, and that's not surprising. Among pregnant women, the prevalence has been, like in previous studies, is high. So treatment coverage, we have now reached something like estimated 22% of estimated total burden. I mentioned in the beginning, the 95,000. So we still way to go, but still this has been quite achievement so far, past since now 24, now 26, 2 years. The cure rate, the viral cure rate is at 12 weeks is 94%. As well as the short from screen, I think relatively short, I would say, from screening, confirmatory tests, as well as start of treatment is less than 2 weeks. And lots to follow up, same figures that MSF already quoted. So I would consider this kind of setting, lots to follow up is very much commendable. So, one of the questions we say that in this kind of densely populated, population, and also some newcomers and they movement of the Rohingyas. So how about the compliance? How we can ensure that we can have good compliance in our program? So here are some of the enablers listed there, from coordination work to integrated care cascade. Link is from mentioned already, from the screening to treatment. We have this early warning system to track the surveillance, and then of course from the side that we say that we have treatment duration is definitely shorter than if you compare with tuberculosis or other chronic diseases or communicable diseases. And it's quite tolerated, the drugs, and we have very clear endpoints how to achieve. So this is some of the enablers how our program would be, possible in this context. We do have challenges, and I think that mentioning here only a few quickly, that the disease burden is enormous, right? And unless we have enough speed up our efforts, so maybe the transmission will continue in community without space response effort. We have not have a reinfection that we have not looked at, but these are some of the challenges. And it's costly, we know, a partner are with us, but whether we do have some level of partner fatigue, donor fatigue, so that whether we are able to sustain this effort. But the most critical thing that how the national system would be integrated. Of course, in Bangladesh host community, this is not a huge issue, but again, we need to have some system integration. All right, so a few snapshot of what we already had mentioned, that how we say that elimination will be feasible in humanitarian setting, coordination effort, integrated service delivery, linkage from screening to care, and then we need to assure our continuous supply chains. And this is really the community are with us, so we are able to let's have a high level of compliance as well as participation. This is a kind of proof of concept so far. We have a way to go, but I do believe that that with this experience, we are confident that continuing this effort jointly with partners, we are able to achieve. So my very last slide, I take the title that we need to continue to raise awareness, like this seminar, as well as mobilize resources. But I have some specific here listed some of these considerations, how we can eliminate, follow and follow through our elimination effort. We said about the financing of diagnosis treatment, community-based screening, we mentioned that, and how we can scale integrated across all services like preventive mother-child transmission, other hepatitis diseases connected to like HIV screening or syphilis screening in the MCH clinics. I mentioned already how to strengthen national ownership and system integration, and then some long-term financing policy alignment, as well as partnership and collaboration. I cannot, thank enough that we have partner engagement. Very strong lineup here on my last slide. As you see that from the UN partners on the first, of course, the ministry and health sector, UN partners, a long list of implementing partners, as well as donors, all are captured there, hopefully in this slide to acknowledge them. So let me thank you for your attention, and over to you, John.
Thank you so much, Dr. Tran. There's a few questions for you in the Q&A. Please type your answers to those while I introduce the next speaker, and please be available for our discussion period later in the program. Let me turn it now to my colleagues at IOM. I'm not quite sure who's going first, so please just speak up and introduce yourself. Thank you. So Dr. Soma? Perhaps you're on mute, Dr. Soma?
Yeah, thank you. Maybe if you could share on your end. I think I'm having some challenges sharing on my side.
Okay. I think Lindsay can do that for you.
Thank you. Yeah, so thank you. My name is Dr. Emmanuel Soma. I'm going to make a presentation with Dr. Charles, Eric Halder, and Dr. Abid Hassan. We work with IOM based in Cox's Bazar. We're going to give some practical insights into how we respond to the hepatitis C epidemic among the Rohingya refugees in Cox's Bazar. You can go to the next slide. Thank you. So we will structure this presentation in a way where we'll give a short introduction about the IOM's response in Cox's Bazar. Then we'll look at the IOM's operational role in Hep C. Then we'll consider the operational challenges, the clinical challenges, and then we'll go into detail about the study that we are currently doing about the causes of the high prevalence, and then look at the coordination mechanism and priority actions. Next slide. So just a background about IOM in Cox's Bazar, and maybe just to start with the Rohingya population, just to add to our voice. This is a population that has faced repeated displacement from Myanmar due to conflict. And we know that the largest influx happened as of 2017. About 700,000 came into the country. And as of now, as of December 2025, it's at least 1.15 million refugees who reside in 33 overcrowded camps, and also that's in Cox's Bazar district, as well also in on Basanti Island, and they face poor living conditions, and this predisposes them to the recurrent disease outbreaks. We've had different outbreaks of diphtheria, measles, COVID, even COVID-19 acute watery diarrhea or cholera, and even dengue. And IOM as a partner ensures that we deliver multi-sectoral humanitarian support, and this covers health, mental health, and psychosocial support, WASH, shelter, site management, protection, disaster preparedness, and also livelihood for the Rohingya refugees and also the affected host community. Currently, IOM supports and also operates in 32 health facilities across Cox's Bazar, Basanti, and Noakhali, and we average around 1.2 million clinical consultations a year, and this covers primary healthcare, secondary healthcare, referrals, sexual and reproductive health, and MHPSS. And as has been highlighted by the other colleagues, the Rohingya have been noted to have a high endemicity of hepatitis C, and unfortunately we see the pregnant and also the young women are at high risk, yet we are not able to provide treatment for them. And we closely coordinate with the government of Bangladesh, WHO, MSF, and other UN agencies, plus also other health actors that were quite clearly shown by my previous colleague. Thank you. Next slide.
Thank you, sir. So from here, I'll be sharing the IOM's frontline experience responding to the hepatitis C epidemic among the Rohingya refugee population. So let me begin with how IOM has structured its operational response. Our approach is fully integrated within routine healthcare delivery, meaning hepatitis C screening, diagnosis, and treatment. They are not standalone program. They are embedded into the primary healthcare system, serving this community. At the community level, our community health workers conducted active case searches, going door to door to identify individuals who may not otherwise seek care for it. And for screening, we use rapid diagnostic test for all individuals over the age of 11, which enabling mass screening at scale. Currently, we operate across IOM 11 direct health facilities, one Government of Bangladesh health facility, and 5 primary healthcare centers that is run by IOM's implementing partners. We have also planned to expansion of 11 additional facilities spanning IOM and Government of Bangladesh site in both Cox's Bazar and Basanti. For confirmatory diagnosis, we have established Sentinel surveillance at 6 of our primary healthcare center, where samples are collected and transferred for RT-PCR testing at the WHO IDCL lab. Treatment is then provided at 3 primary healthcare centers with a 3-month regimen for non-cirrhotic cases and 6 months for those with cirrhosis. And critically, we have structured a referral pathway from screening to Sentinel sites to treatment center. And for the most critical cases, IOM's dispatch and referral unit, which provides 24/7 support across all camps, and it provides direct transport from the camp to the district shoulder hospital and even the divisional hospitals. Next slide, please. Now, while the operational framework is in place, implementing it in the field is far from straightforward. So I want to be candid about the challenges we face because they are significant. The first and most pressing challenge is the sheer burden on our health facilities. The prevalence of hepatitis C in this population is extremely high, which means mass surveillance becomes a necessity, not a choice. So this had required extensive involvement from our healthcare workers who are stretching an already overburdened systems and leading to an excess delays and long wait time for the patients. So compounding this is a serious shortages. Sometimes there is serious shortages of diagnostic kits and medicines. The treatment medication must be imported, and because primarily it was from India at a cost of approximately 100 USD per patient. While this is significantly lower than the 820 USD price in Bangladesh, so meaning it remains a heavy financial burden given the scale of need. To date, IOM has been able to support treatment for approximately 1,000 patients, and WHO has supported over 2,000 patients through IOM. But the demand continues to far outpace available resources, so we urgently require further support. Next slide, please. So beyond supply, we face two additional operational challenges that affect our ability to ensure treatment completion. The first is patient loss to follow-up. Hepatitis C treatment requires months of adherence, but the Rohingya population is highly mobile. Movement between the camps especially and the outside of the camps for the economic activity, meaning patients frequently miss their appointment or discontinue treatment before completing the full course. This is not a simply logistical problem. Incomplete treatment can contribute to resistance and reinfection. The second challenge is related to documentation. Many newly arrived refugees lack proper identifying documents. This creates delay in verifying their identity, enrolling them into the care, and results in missed opportunity for early intervention, particularly among the most vulnerable who may arrive in poor health. Next slide, please. Okay, so along these operational realities, we face important clinical challenges that we want to highlight for medical community joining us today. The first is treatment limitation for a specific population. Current treatment protocols have limited, or in some cases, no options for children under the age of 11 and for pregnant women. These are two highly vulnerable groups, and the gap in available treatment option for them is a significant clinical and ethical concern that the global health community must address. And the second clinical challenge is the absence of clear guideline for managing reinfection and complex clinical cases. In a setting where transmission risk remains high due to living condition, reinfection is a real and recurring phenomena. So without standardized guidance for the clinicians, including our own terms, like we may face significant uncertainty in how best to manage these cases. Next slide, please. So here I want to draw attention to a challenge that is both an operational and clinical concern: the co-infection of hepatitis C with TB and HIV. So co-infection with these diseases significantly worsen disease severity and dramatically complicates treatment, as patient must manage multiple drug regimens simultaneously. And even for this particular co-infection, we cannot immediately start the treatment because of the co-infection. So we have the data from our own assessments through March 2026, which actually tell a sobering story. Among 714 people living with HIV assessed by our teams, and from that 714 people, 61.14 were found to be co-infected with hepatitis C. And among 75 TB patients, 16 had a hepatitis C co-infection. So these are not the marginal figure. They represent a substantial proportion of the most medically complex patients in our care, who require actually highly coordinated and multi-disease treatment. So in closing, for the operational challenge, IOM team in Cox's Bazar actually is committed to continuing and strengthening the response. Next slide, please. I would like to request my colleague, Dr. Charles, to carry forward from this slide. Over to you, Dr. Charles.
Thank you, Dr. Emmanuel and Dr. Rabid. This is Dr. Charles Erihalder. So the earlier speakers mentioned about the high prevalence of hepatitis C in the Rohingya refugee population, but there are some questions remain. What are the factors that are causing high prevalence? So the high prevalence, the cause of the factors, it is still unknown. So that's why we are investigating the socio-demographic factors or the medical factors, traditional or behavioral factors that are contributing to the hepatitis C virus among the Rohingya refugee population. So we have started this study last year. We are almost at the end of this study. The analysis is also completed and we'll publish the results soon. Next slide, please. So what we are investigating here and what the results will publish, it's about the socio-demographic characteristics, the relationship with the high prevalence of the hepatitis C. We are exploring whether there is a relationship between the occupation, their past occupation in the Myanmar, or is it related with the arrival in Bangladesh in terms of the years, or is there any relationship with the family status of the family members and other demographic factors? We are also investigating about the medical history, for example, the blood transfusion, the history, place, and time, and also the other medical histories like medical injections, needle prick injuries, surgeries, hospitalization, or the procedures, also co-infections and comorbidities. We are also saying about the home delivery, whether it is related with the high prevalence, and some procedures like the evacuation of the consumption products. So these things we are exploring from the quantitative perspective. We're also exploring about the traditional practices, for example, the circumcision, tattoo history, or piercing histories, or shaving, whether these are related with the high prevalence. And we are also exploring about the other risk factors like recreational injection drugs, or the history of incarceration, or the spousal history or the family history of hepatitis C virus. We are also exploring about the sexual activities, whether it is related in this area, and mental health impact we are also exploring, and the knowledge, attitude, and practice we are also exploring in relation to the high prevalence of the hepatitis C virus. So in this study, we are doing a biphasic approach where we have the both qualitative and quantitative part. We are in phase 1, we completed with the quantitative part where we had a case control study engaging 900 cases and 900 control. And following that, we had a qualitative study composing of the focus group discussions and key informant interviews with the caregivers, healthcare providers, and the community members. So with this study, we hope we can find out the risk factors for the high prevalence of this disease here, and that will help us in addition to the case management, in addition to the all other measures. It will help us for the prevention to develop a proper risk communication and community engagement strategy so that we can reduce the transmission in this area. Thank you very much.
Yeah, thank you. Next slide. So I'd like to highlight some of the strong coordination mechanisms that is helping the response and also still presenting a challenge. We continue to implement under the overall policy support of the government of Bangladesh through the RRC office and as well the civil surgeon office. And our main primary stakeholders still remain to be the Rohingya refugees, and we are actively engaging them through the community health workers and community-based activities. There's a coordination at the screening sites of the local community health workers who they refer to the screening sites from the local catchment. There's also the sentinel sites for the confirmatory diagnosis, and this also coordinate directly with the camp-based health facilities where the referred RDT positive cases are sent to the sentinel sites. And in the treatment center, there's close collaboration within IOM and also non-IOM sentinel sites. We work closely with WHO, the Hepatitis C task force that's in Cox's Bazar to ensure for the response, and this through the technical guidance and for supplies, and also work closely with other actors like BRAC, who are mostly for HIV, TB, IRC, MSF, UNICEF, UNHCR, and also for resource sharing. And there have been quite great efforts in which partners have been contributing, whether it's diagnostic kits or whether it's treatment to the entire response. And with these dedicated sites, we ensure there's sentinel surveillance and there's treatment support for efficient use of resources and avoiding duplication. Thank you. Next slide. Finally, I want to speak about the priority actions and where we feel that support and collaboration are needed. And this is just to add to our voice to the discussion. As IOM, we will carry on with concluding the research on identifying the risk factors. So we will not share much. We would want you to read the study once it's out. It will be quite interesting, but also we would encourage all actors to undertake extensive risk communication and community engagement management to halt transmission. We know there are various perceptions of the disease among the population. We also need extensive additional human resource. You know, at the camps, there is quite a high turnover, and we also need the supplies. We've highlighted the significant cost to treat the actual or estimated cohort based on the prevalence, and also to support the mass screening, diagnosis, and treatment of all patients, and also, if it's possible, through the government for the advocacy of the production of Hep C medicines in Bangladesh at a much lower cost as it is for other medications, and as well, how can we ensure the availability for all treatment of all age groups, especially the under 11s that are not currently considered, and also how we can factor in those that are pregnant. At this moment, I would say thank you to the presenters and also to you for listening in, and would welcome the questions in the chat box and also at the end of the meeting. Thank you.
Thank you, Dr. Soma. Thank you all to your other IOM colleagues for sharing their knowledge of the response and what's our critical next steps. And again, we'll be exploring those in our discussion period. Let me turn now to Dr. Toha Bhuya, who is part of the Refugee Relief and Repatriation Commission in the government of Bangladesh. Welcome, Dr. Bhuya.
Distinguished colleagues, partners, and members of Global Health Community for Global Hepatitis Elimination, Assalamu alaikum, and warm greetings from RRC office and as well as Government of Bangladesh. I am honored to speak today on behalf of the Refugee Relief and Repatriation Commission, Bangladesh, as we address a critical yet often under prioritized of Commission, Bangladesh, as we address a critical yet often under prioritized issue, hepatitis C among Rohingya refugees in Cox's Bazar. The Rohingya crisis remains one of the largest protracted humanitarian emergencies in the world. Nearly 1 million forcibly displaced Myanmar nations reside in the extremely dense camp settings. These conditions, overcrowding, limited specialized healthcare services, and high vulnerability create a fertile ground for silent epidemics like hepatitis C. Recognizing the gravity of this challenge, the government of Bangladesh, through the Rohingya Refugee Relief and Repatriation Commission, has demonstrated strong political commitment by establishing a dedicated hepatitis C task force in Cox's Bazar. This task force brings together government authorities, UN agencies, NGOs under the unified coordination framework led by RRC, ensuring the policy decision, resources, mobilization, and the programmatic responses are aligned with the accountable. The RRC office has played a central conveying role, working alongside the health sector to oversee program expansion, quality assurance, and data governance across all of the camp settings. According to global estimates from the World Health Organization, over 58 million people live this chronic hepatitis C, with approximately 1.5 million new infections annually. In humanitarian settings, the burden is often underestimated due to limited surveillance in Cox's Bazar camps. Emerging programmatic data and targeted screening suggests the hepatitis C prevalence may be higher than the national average of Bangladesh, particularly among adults with prior unsafe medical practices, individuals exposed to unregulated blood transfusion, and the population with the limited awareness of transmission routes. To put this perspective, while the general host community in Bangladesh carries the hepatitis C prevalence of only 0.2 to 1, prevalence among the Rohingya population, the Cox's Bazar ranges is 13.2 to 19.6%, and among the pregnant women, it reaches high as 15%. They tell us that this community carries this appropriate and devastating burden that demands urgent, targeted, and sustained action. It is this stark contrast and makes the Rohingya population epidemiologically unique and morally impossible to overlook. There is a small history. Government of Bangladesh first start treatment 2018 treatment of hepatitis C 2018. First 500 patient. Then MSF started their journey from 2019, and it is maybe more than 30,000 now. Key challenges. The response to hepatitis C in this setting faces two key challenges. First, infection prevention risks persist as inadequate sterilization practice, informal healthcare providers, lack of community awareness continue to fuel transmission. Second, stigma and awareness barriers cause many individuals to delay or avoid care altogether, fearing social consequences of a positive diagnosis. Our strategic response. Under the leadership of Government Bangladesh and RRC, in collaboration with partners such as UNHCR and WHO, we are advancing a multiple pronged strategy. On the prevention front, we are strengthening infection prevention control across the health facilities, ensuring safe blood transfusion system, and delivering community level awareness campaigns through trained volunteers. For screening and early detection, we have integrated hepatitis C testing into primary healthcare services, introduced targeted screening for high-risk population, and deployed rapid diagnostic tests situated to camp settings. On treatment and care, we are scaling up access DAAS, developing referral pathways for complicated liver disease, and building the capacity of healthcare workers in hepatitis C case management. Finally, we are strengthening health information system for case tracking and monitoring, fully aligned with the WHO Hepatitis Elimination Strategy 2030. A landmark program from diagnosis to treatment on 6 March 2024, WHO and aligned with Bangladesh government launched the first formal hepatitis C treatment program in the Coxbazar camps, marking a historic milestone in the humanitarian health response. The program began with 2 treatment centers established by IOM, MSF, Save the Children, SCI, and has since expanded to 9 centers across the camp. This expansion reflects the strong coordination and unwavering commitment of all partners involved, anchored by the health sector and the RRC office, which have maintained a robust coordination architecture and ensures seamless referral pathway and accountability of every level. What makes this program truly remarkable is its scope and significance. This is the first end-to-end hepatitis C initiative in the WHO Southeast Asia region CRO, spanning the full continuum from the diagnosis to treatment, and it is operating in what is recognized as one of the highest burden humanitarian setting in the world. The program has adopted a powerful integrated care model alongside hepatitis C. All screening centers now test for hepatitis B, syphilis, and HIV, ensuring that no co-infection is missed and that patients receive holistic, dignified care in a single visit. Every health facility across the camps serves as an active screening point, with rapid linkage to care as a core operational standard. The results speak for themselves. The program has achieved a treatment success rate is almost 95%, on par with the best outcomes reported globally. This is a testament to dedication of frontline health workers, the strength of multi-agency coordination, and the resilience of the Rohingya community. The role of the global platform. Today's the global platform provides us a crucial opportunity to mobilize resources for scaling up, screening, and treatment, to share best practices for the from the humanitarian settings, to advocate for equitable access to life-saving hepatitis C medicines, and the strengthen research collaboration for better epidemiological understandings. We must recognize that elimination of hepatitis C is not only the clinical goal, it is a matter of health equity and humanitarian dignity.
Thank you.
Call of action, I would like to conclude with these three calls. First, invest in hepatitis C programs in humanitarian settings. No population should be left behind. Second, expand access to affordable diagnostics and DAS through global partnerships. Third, integrate hepatitis C into broader primary healthcare and US Upazila health complex frameworks within the refugee responses. We have also some shortage of funding for Asia, RCCE, counseling, awareness staff, and secondary infection during the under 11 child treatment. And I think we already taken much time. Thank you.
Thank you very much. Very important comments. I greatly appreciate them. We're now going to turn it over to our discussion period. If I could have a return to the slides, I think just to start off, I think I had just one area that I wanted to emphasize, to take the prerogative of the moderator, is to first thank everyone for a very remarkable response in access to increasing access to screening, linkages to care, and treatment for this marginalized population. I think it demonstrates the power of hepatitis C therapies achieving high cure rates in these kinds of circumstances, and how when you get a simplified approach, you can really expand access to care. That said, I found striking that the attention to screening, care, and treatment is greatly larger than the focus on why are these people getting infected. I view this as an epidemic, not as an endemic, as was referred to this population earlier, where you have a population almost 20 times higher prevalence than the other population of Bangladesh. Why are these people getting infected is a key question, so that you can prevent transmission. Otherwise, you'll continue to have this current of new infections that you're trying to reach through screening and treatment, but you're not decreasing that stream at all, albeit you have some reduction in force of infection the more you treat. It's really important to focus on those modes of transmission. Multiple surveys have been done. You have screening going on and patient care. Very interested to hear from all of those involved in the response about what you're learning that you think is truly remarkable, and probably most likely being the major modes of transmission. In my knowledge of hepatitis C, I'm struck by, in Southern Asia, there's the highest risk of unsafe injections have been identified through various surveys, including those by WHO. So I'm very interested to look at unsafe injections through traditional healers and in more routine medical care settings. And so that kind of information can come from more information, from more examination of the survey data, gender, age, time in the camps, etc., and your interactions with patients. And I really would encourage all of you to view this as just a classic outbreak response, and seeing how we can accelerate the acting on the information we already have while these more formal studies are underway. And I'm very interested to know what has been the interaction with the community and community leaders to help them become better aware of this epidemic and already began to advise with the information we have how these probable modes of transmission can be avoided. So that's my call for you as we enter into our discussion. But let me turn it over to Dr. Ali to say hello and present any introductory remarks, and then we can get our discussion going. Thank you.
Like John, really, I'd like to thank you for organizing this webinar. And I know you are the key person working with me for making this Rohingya studies on viral hepatitis prevalence, hepatitis B and C, particularly hepatitis C. And you are part and parcel with me, particularly for this publication. And now I'm happy that the study which we made in 2017 on the 300 pregnant women, and followed by 2019 on 2,000 patients, which showed about 1 in 5 there was persons having hepatitis C. And now the WHO, it was our motive that to bring this high prevalence among the global community, Bangladesh and global community. Now I'm very happy to see that now this has gone achieving our desire, that the global community, particularly WHO, MSF have come forward, and a lot of work is going on. And really it is highly concerned to see that about more than 95,000 Rohingya refugees have been already diagnosed to have hepatitis C, and they are getting treatment. But the treatment regime, total treatment has come forward very less, about 35%, 35,000. And more concerned, the children below 11 years not getting treatment, and pregnant communities not getting treatment. When we made this study at that time in 2017, there was 8% pregnant women having hepatitis C. Now I saw it has come up to the 15% pregnant women having hepatitis C now. It's a highly concerned. And I think, and really, so I'm very much concerned that all the instances are going. MSF is doing very good work, but there is lack of clear guidance regarding the treatment, strategy and control. And I saw that a lot of new cases are coming up. And what is the most important source of this new infections? At that time, and co-infection with hepatitis B and C, co-infection with HIV. And it is also very rampant. When we made the study, it was only among pregnant women we found in 1%. Now it is co-infection, so the very high prevalence of co-infections. All these things are going to be a complicated situation. They are working, but the situation is very much advancing very rapidly in a very serious way. And I like to know these peoples had a long time having exposed to hepatitis C, hepatitis B, sometimes co-infections. What is the prevalence of chronic liver disease and HCC among them? That needs to be chalked out for getting those who have already developed liver cirrhosis or hepatocellular carcinoma. They should be bring under treatment strategy as well. They should not lie. They should not die in the camps untreated. That is my most important concern. I think WHO and MSF is working very good work, and I really congratulate them. And I'm very much happy that what we initiated in 2017 or 2000, now it has come to the light, to the global attention, and the thousands and thousands of people of Rohingya refugees are getting the treatment. This is our very happiness. And I like to thank John and particularly all the distinguished members of CGHS for working with me for the initiation of this spaces, and this or now it is also you are continuing this also regarding the issue. I'd like to thank all the speakers who has participated and brought many things which we could not believe in 2017 and 2000 also. Thank you all. Thank you, John.
Thank you very much, Mohammed. I know we're running a little bit on time, but just looking at chat, it seemed like there was a number of questions, and you raised it, was the issue, the question about hepatitis C among pregnant women in the camps. The prevalence seems to be quite high. Is treatment being provided during pregnancy, and if not, how many of those women are lost to care after delivery? So let me just call on Dr. Wasim or Dr. Soma. Dr. Tran, if you have any experience with that. Thank you. Wasim? Dr. Tran?
Dr. Wasim, you can go ahead. I will complement.
So between the period we have that 2020 to 2024, we are not used to screen the pregnant lady. But when we started this test and treat campaign back in 2025, we are screening the mothers, involving them. So to define loss of follow-up, it's a bit tricky for these pregnant and lactating women, because there is no defined period so far in all the global recommendation is stop until the complete cessation of breastfeeding. So that's why we do periodic follow-up, like every 9 months or after every 6 months, we are communicating with these women. So it is a bit difficult to conclude this at this moment, the total loss, the follow-up.
Okay. IOM, do you have any experience, please?
Just to come in, I mean, since we follow similar guidelines, the guidance has been through the leadership of the task force and WHO that at the moment that we only have been we've not been treating the pregnant women and under 11 years old, and I think also because, as we say, there's need for unified treatment protocol guidance, and also so based on the guidance, we've not been doing that, but also the aspects of follow-up, it's still, we do our best since we ensure the community health workers try to know the locations, exact location in the camp of where the patients stay. But as we know, with the mobility, there's still those that are lost to follow-up. But we, as a team, we continue to do our best. Over.
Okay. Thank you.
Yeah, just may I just briefly that in our this guideline that I mentioned, it will be published in a couple of weeks officially. But even in our new guidelines, because we don't have now the world is missing the safety data for pregnancy and breastfeeding period, so it's still not recommended. It's contraindicated for pregnant women during entire pregnancy and also lactating period. But what we anecdotally learned from the field, that some women are coming forward, even they say that they're ready to interrupt the pregnancy in order to keep the treatment on. So just showing how eager and the population really appreciate this intervention.
Thank you. Very quickly, we have a TIP Hep C registry where we're seeking information about women who do decide to be treated during pregnancy. That was started with our colleagues at the US CDC. You can go to globalhep.org to learn more about the TIP Hep C registry of HCV pregnant women. Again, I encourage you to increase our attention on interrupting the modes of transmission that seem to be quite common in this population. I know we're right at time. I want to again thank all the speakers for their work as well as for their presentations. Thanks to Mohammed for joining me. in this panel discussion. And let me turn it over to Tanjida Basanti for closing remarks as you complete our evaluation poll. Thank you, Tanjida.
Thank you, John, and thank you all of our distinguished speakers for keeping your time for in these valuable discussions. And here is the evaluation poll. We would like to address a couple of few seconds in here for the evaluations. Along with, I would like to introduce. I would like to draw your all of our attention for our partners. Like in this webinar, that is definitely an eye-opening. Hepatitis C response in Rohingya camp, though it is fragile, but we can hope for elimination. And you are the proven materials for that hope that it can possible. But it depends upon so many factors. We can figure it out, and we just observe from all of your presentations that those are the factors: equitable, effective management, strong coordination, community-based approach, sustainable global funding. Any disruption that risk for life-saving progress in these matters. And that's why through this platform, we are aiming forward with a clear and collective outcome of definitely strengthening multi-sectoral coordination, obviously. And we really, I would like to appreciate that for already ongoing multi-sectoral approach under WHO and MSF and IOM, UNFPA, Save the Children, IRC, all are doing, and along the donors party as well. Identifying priority action for scale up, building capacity across the systems and partner, exploring opportunity for resource mobilizations. Because ultimately progress, not only just we are enough now, we achieved so many things and we are now satisfied, but we have to think how effectively we move forward together with the elimination goal of WHO that 2030. So here I would like to finish with this last speech, and the last slide. There is a contact detail from that you can contact with Dr. John. There is a mail address and along with the contact informations. Thank you all. Thanks. I truly appreciate and grateful that we can sit together, discuss together, speak up, and that's the matter most. Thank you.
Thank you. Thank you very much.
Thank you all.
Thank you again for a very informative and hopefully call to action for all of us all to become more involved in this response. Let's all do our part to reduce this extraordinarily high prevalence and ongoing transmission of hepatitis C among this large marginalized population. So I look forward to continuing the coalition's engagement in this issue. And again, thank you all to the organizations already involved, and I encourage others to join that response. Thank you again, and look forward to your comments by email at the email address provided for me. Thank you again, and continue to work to eliminate hepatitis C around the world. Thank you.